السلام عليكم جميعا. مساء الخير. You are welcome to MENA Blue Circle program, Time and Range. I introduce myself. I am Mohammed Sandid, President of the Lebanese Diabetes Association, and I am endocrinologist. I am President-elect of the International Diabetes Federation, Middle East and North Africa. The scientific committee of our MENA IDF asked me to moderate this important webinar sponsored by LifeScan, in which a four of doctors, professors who are experts in this field will speak, and they are in the order of the lecturers. The first speaker, Rashid Malik, professor, head of Internal Medicine Department, University Hospital Sétif, Algeria. He will talk in 20 minutes about the time and range for domain in glycemic control or a glucose variability alternative. The second speaker, Nancy El-Barbari, professor in pediatric department, Ain Shams University, Cairo, Egypt, that she will talk in 20 minutes also about how can we correlate time and range and complications, impact of CGM on diabetic complications. The third speaker, Asma Deeb, professor chair of pediatric endocrinology, Sheikh Shakhbout Medical City Clinical Professor at the Gulf University and Khalifa University, UAE. She will talk in 20 minutes about time and range for SMBG patient. How do we adapt? So the last speaker, Bassam bin Abbas, consultant section of endocrinology and diabetes, King Faisal Specialist Hospital and Research Center, Riyadh, Arab Saudi. His topic in 20 minutes, how can we improve the time and range to our SMBG patients? In the end, it will be a half-hour panel discussion. Do we have time to questions in this end of the webinar? So please type your question in the chat in the right of the screen, and we will try to answer as many questions as possible during the webinar after the session. We will proceed the survey by email for you to provide your feedback on our webinar. DHA certificate will be sent to the registered email 3 weeks from now. So the CMA will be added to the system webinar this week. Now we move to the first speaker, my friend, Professor Malik. The floor is yours.
Thank you, Mr. Chairman. Thank you, Mohammed, for this introduction. My topic is the time in range for domain in glycemic control of glucose variability alternative. I will begin my topic with the glycemic variability on patient. The glycemic variability is the measurement of blood glucose fluctuation through the day. There is some evidence that glycemic variability is a predictor of cardiovascular risk and induce epigenetic change and modulate the expression of alternative hypoglycemia and hyperglycemia may have a deleterious effect on the occurrence of glucose variability, and this can be measured between individuals or within the same person. We have inter-individual variability and intra-individual variability with different curve, with different situation with type 1 and type 2 diabetes, and we must change the doses of insulin between inter-individual or in intra-individual. Intra-individual variability is considered a major obstacle to achieving optimal glycemic control, and fluctuation in blood glucose can contribute to hyper and hypoglycemia. The glucose fluctuation are a process with two dimensions. The first one is the time in range. The time in range is the time passed in the target range, in hypoglycemia range and hyperglycemia range, with exactly the time above, within, and below target range. And generally, we have from the glycemic target from 70 to 180 milligram per deciliter. For the amplitude, we can result from SD, from age, and for mood. This slide is just a reminder of the evolution of technology in blood glucose measurement. After urine analysis, capillary blood glucose took place with blood glucose meters, which, despite their improvement over time, do not meet our needs. HbA1c has revolutionized blood glucose monitoring and has shown its clear implication in the occurrence of chronic complication of diabetes. After self-monitoring with conventional meters, we have progressed to interstitial meters, glucose analysis with continuous glucose monitoring, and currently with the flash glucose meter. The self-monitoring blood glucose only provides point-in-point information of blood glucose level, and it cannot measured in sometimes high and low blood sugar levels by this device. For the HbA1c, is the main pillar of blood glucose measurement. However, the HbA1c has limitation. This limitation provides only an approximate measurement of blood glucose. It is unable to identify glucose variability or hypoglycemia, and cannot be relied upon in certain conditions like renal failure, hemoglobin abnormalities, and others. If you see this slide, we have two sorts of patients. We have the first curve with the blue sky with many fluctuation of glycemic, hyper and hypoglycemia, and the second curve with navy blue color. We have a patient with flat curve, and the two patients have the same HbA1c, 7.8%. So the glycemic variability is independent of HbA1c. You have the third measurement is with CGM. Real-time provides real-time numerical and graphical information on current glucose level, glucose trend, and direction, rate of change of glucose. And we have intermittently viewed provide current glucose value plus retrospective the scan. In this randomized open-label crossover trial, the primary endpoint was the mean difference in the percentage of time spent in normal glycemia. It was higher during CGM, representing with the blue curve, than during self-monitoring blood glucose with the red curve. And the number is 64% versus 55.4%. For the secondary endpoint, during CGM, we have the number of severe hypoglycemia event was lower, 40 events versus 34 events. And now we move to the timing range. The timing range refers to the time spent in an individual's target blood glucose range. And usually we have the target from 70 milligram per deciliter to 180 milligram per deciliter, but occasionally we can have 70 to 140 milligram per deciliter. Secondly, the percentage of time passed below the TBR or above the TR indicated hypo and hyperglycemia respectively. The time can be used as an appropriate endpoint in clinical research and as a measure of glycemic control in patients with diabetes. Emerging evidence suggests that tire is inversely correlated with the risk of development microvascular and macrovascular complication in patients with diabetes. Now, you see together how to measure time in range. You should use at least 14 days of glucose data, and if you have a BGM, the more finger sticks you take throughout the day, the better picture you will get of your tire. Make sure to get reading over at least 2 weeks, ideally with some finger sticks taken after meals and overnight. And with this, you have a report of the total of number of finger sticks and the total of finger sticks in time in range, and you can have the time in range with the if you haven't device like freestyle or other. If you have a CGM, the tire is calculated automatically in the software or with application that comes with your device. Look at this figure. We show why the tire is important, why the time in range is important, and you have this clinical example with the same HbA1c, 6.7% and 6.8%. We have the same average glucose, 147 and 149 for the second patient. But when we have the time in range, we prefer this sort of patient when we have the target in the time in range for 84% for this patient. But in the second patient, we have only 52% in the target of glycemic control, and below target we have 15%. You can conclude for this simple clinical sample that the time in range provides more useful information than HbA1c alone and should complete it. And the time in range in the target becomes the new standard for glycemic control of patient. In this trial of this data of the DCCT, you have the association of time in range with the microvascular complication. And I think you will have more details with the second lecture of my colleagues. And I can see only that every 10% increase of tire in range, the hazard ratio for progression of retinopathy reduced by 64%, and for microalbuminuria was 40%. So you have guidelines from the International Consensus on Time in Range in 2019. These guidelines have guidance on targets of accessing glycemic control for type 1 and type 2 diabetes and elderly and high-risk individuals. In the first line, you have the time in range, the time below range, and the time above range. It is interesting for the majority of the patient, type 1 and type 2 diabetes, to have more than 70% of the glycemic in the time in range. This equal more than 16 hours and 48 minutes. For the patient, elderly or high-risk patient of type 1 or type 2 diabetes, we accept more than 50% or more than exigent for this sort of patient. You can also have predicted HbA1c for a specified percentage of time in range, like we have this table with the average of glycemic and HbA1c with the recommendation in 2018, etc. when you see the table, we can, for the example, for 17% of tire, you have the equivalence of the HbA1c 7%, and the increased for percentage of tire reduce the HbA1c and inversely. And generally, every 10% increase in tire equal 0.5% reduction in HbA1c with type 1 diabetes trial. And for type 1 and type 2 diabetes, we have the result, the same result, about 0.8% reduction of HbA1c for 10% of increase in tire. This is very interesting in practice. And so you have the different glycemic target for different population. You can have three sorts of population for the guidelines of the consensus, international consensus for the tire. The first one is the people with diabetes, type 1 and type 2 diabetes, and the majority have the 17% or more and less than 40% below the target. For the patient, we have gestational diabetes. We have 85% or more in the target. And pregnant with type 1 diabetes, we have 70% or more in tire of range. And all the academic society published the update or the new guidelines with these different glycemic target, ADA, AACE, EASD, etc. The time target can combined with AGP report or data for a fuller picture glycemic health and as a basic for management, for therapy, and make treatment decision. We have three parts of in the AGP of the report AGP. We have the metric and target with the tire. We have the second report, it's the AGP profile days. And the third one, the daily views. We have every day the fluctuation of every glycemic before, after lunch, etc. And with the three report, we can adjust the treatment. We have make a lot of decision. I make you an example for this. Is using percentage of time in range in clinical practice. This example is from a patient with type 1 diabetes. In the first step, you have to analyze. In the analyze, the question is what is going well and identify for change. In the second step, you have how the question is how to use it. Where am I now? How can I continue to optimize time in range with all these results? And finally, or the third step, you have to have a question how to act. And for this example, for this type 1 diabetes, with this fluctuation before and in the morning and after the dinner, etc., you have agreed to decrease long-acting insulin and move to more consistent time of day, and agree to work on giving insulin before eating. In conclusion, you can say that over and above standard glycemic parameters like blood glucose and glycated hemoglobin, glycemic variability is a target parameter for optimal glycemic control. Glycemic variability is a well-established risk factor for hypoglycemia and a suspected risk factor for diabetes complication. The percentage of time in range is a dynamic measure of short-term and medium-term glycemia. It is a new concept in diabetology, defining the percentage of the length of time in which the patient stays within a predetermined range of blood glucose. The time in range is considered national and visibly responsive to change in diabetes management. Importantly, it is also been linked to the risk of developing complications associated with diabetes and can be understood by people with diabetes and healthcare professionals alike. And finally, let's not forget the well-being of the patient. We have moved from 1,825 finger sticks on average to 26 finger sticks per year. And thank you for your attention.
Thank you very much, Professor Rashid Malik, for the excellent presentation. We'll take the questions in the end. We now move to the second part of the presentation of today with Professor Nancy Barberia, Professor of Pediatric Endocrinology and Diabetes from Ain Shams University. And Professor Nancy will cover the issue of how can we correlate time and range and its complications.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Professor Sandid and Professor Hassanin, for your kind introduction. And thank you so much, Dr. Rashid. Actually, I've already, you covered a lot. And this will help all of us actually to move and look into the time and range in relation to diabetic complication. So I'm actually fanatic about history, and I really know that all of us need to learn from history, as we really need now fresh air free of COVID virus. But actually looking into the pipeline, how we did from the diagnosis of diabetes till the management of diabetes, just starting from physicians who are tasting the sweetness of urine of the patients in order to diagnose diabetes into time of range nowadays. And look at the second wonderful picture. And I will leave you a few seconds to think how this picture actually correlates to diabetes, and I will come to it later in my presentation. But we as healthcare providers, which parameters are we using to evaluate glucose metabolism? Is it the fasting blood glucose, the 2 hours, the random blood glucose? Is it the HbA1c, the glucosoric profile, glycemic profile, or even the fructosamine? So according to the standards of medical care in diabetes and the section of glycemic targets, we can hear now that the estimated average glucose, looking into the mean as well as the range of the blood glucose, which is not actually a definite certain point. But we are all acquainted with the concomitant occurrence of microvascular complications, wherever you're having higher HbA1c. And this is all known from the landmark study of the DCCT. So with each increase in HbA1c by percentage, you're having increase in the microvascular complications, and vice versa. When you're trying to control your blood glucose values by reducing the HbA1c, you will have a reduction in the micro as well as macrovascular complications. In 2005, Antonio Cerullo was the first one to give us a hint of how postprandial spikes, because of the sharp and high spike of the blood glucose postprandial, will also add to the occurrence of the microvascular complications. And 3 years later, the HbA1c variability also was associated with the risk of microvascular complications. And the famous recommendation from the international consensus time and range have showed us that if we are having a 70% of the day between the 70 and 180 milligram per deciliter, this is good for the decrease of microvascular complication. But let's give you a hint and a little bit flavor of the AGP report meaning. So if you're looking at this report and the same consensus guideline, when the time of range is 47% of the day, this means that you have been within range only 11 hours out of the 24 hours of the day. But looking at the time above range, above the 180 and 25 consecutively, this means that you have been hyper in and out 9 hours of the day. So you can correlate how this hyperglycemia could lead to microvascular complications. And we already know about the demonstration of the linear relationship between the time and range as well as HbA1c. So now we are correlating time of range with different glycemic metrics: the high blood glucose index, the mean glucose, the area under the curve, as well as area and time above 180 milligram per deciliter. So Beck et al. And his colleagues have published the relationship between time and range hyperglycemia as well as HbA1c, and nicely shown the negative correlation between time and range and HbA1c. So the higher time and range, the less HbA1c you're having, and hence less microvascular correlation. And even if we are categorizing the HbA1c and taking subsections, if it's less than 7, between 7 and 8, or even more than 8, you can see the consistent slope between the negative correlation changing time and range with the change of HbA1c. And again, you can see the same identical plot, but now the positive correlation if you're having time above range of 180 in correlation with the change in HbA1c. So are we now facing a case of maturation in the use of time and range? And now we're moving beyond the HbA1c in research and clinical decisions. And this is a paradigm shift? And can CGM now provide new measurement of the glycemic control that has been linked to diabetic complications? Beck et al. And colleagues have published in Diabetes Care a wonderful study gathering the DCCT data, looking into the blood glucose measurement in a 7-point testing, the pre and post meal, as well as bedtime. And they have checked for the center lab, the HbA1c and the blood glucose levels, together with the fundus, as well as the urine microalbumin. So it was a wonderful study having more than 1,440 participants have been able to gather 88% of all possible time points. And what they have done Cox regression analysis, looking at the 7-point testing, computed into the time and range and other glycemic metrics, including the percentage of values above the 180, as well as 250, as well as the area under the curve and the high blood glucose index. And we are again acquainted about the intensive and conventional treatment group in the DCCT trial. But look at the breakdown of this table. Those who had intensive insulin treatment had an HbA1c of 7.3 in comparison to 9.1 for the conventional group. And this corresponds to a time and range 52 versus 31 consecutively. And again, it goes with a time above range, area under the curve, and mean high blood glucose index. What about both nephropathy as well as retinopathy? Again, retinopathy progression rate increased by 64% for each 5% point lower time and range. So this means that you have a progression rate of retinopathy by 28% for each 5% lower time and range. And even if you have compared the HbA1c in the DCC trial versus time and range, you will find again the retinopathy progression rate increased by 32% for each only half HbA1c increment and a lower 6.2 time in range. And it's obvious in this picture. So if you're having time in range more than 70%, you're having a frequency of retinopathy of less than 5% versus 58% if you're having time in range less than 10%. And this goes again the same with the microalbuminuria level. So summarizing the DCCT 7-point testing that demonstrate that time and range strongly associated with the vascular complication similar to the HbA1c. And this strong association occurred by measuring 7 times a day, once every 3 months. Again, this was confirmed using not only the 7, but the 8-point testing, where the 8-point was an overnight measurement. And again, the time in range was 49% measured with the CGM versus 50% measured with the 8-point testing. So it only was not in type 1 diabetics, but again, in diabetic retinopathy in type 2 diabetes. And even if we have break down this figure into the mild, moderate, and even the vision-threatening diabetic retinopathy, and looking into the quartile of the time and range, the black table, you can see that they have the best time and range, and they have the least prevalence of diabetic retinopathy. Moving from retinopathy and nephropathy into the diabetic neuropathy. And again, the Chinese paper looking the same exact figure as the DCCT trial when it's translated into the time and range. And even breaking down both micro and macro, as well as the severe abnormality in the albumin excretion rate. Again, it is consistent, the relation between time and range and microalbuminuria. And this figure actually has shown the 3 microangiopathies in relation to time and range quartile. The best time and range, more than 66.3%, has the lowest prevalence of microalbuminuria. Looking into type 2 diabetics, because the cardiovascular problems are more common in them, even time and range was associated with the carotid intermediate thickness level. And even looking into the cardiovascular mortality, as well as all causes of mortality, again, we can see that the less time and range you're spending, the higher chance of getting cardiovascular mortality. A very nice study moving from micro and macro into even type 1 diabetes pregnancy. And this is very interesting, looking into females in the 2nd and 3rd trimester, and just a 5% decrease in time and range and a 5% increase above range was associated with an increased risk of larger gestational age infant, neonatal hypoglycemia, and neonatal intensive care unit admission. And they have recommended for pregnant women that they keep the time and range above 70%, to be translated that almost 17 hours of the day, they have to be kept within range, and to decrease the time above range to less than 6 hours in order to have good neonatal outcome. This again was confirmed by another publication that has been seen just 2 months ago. But is it only HbA1c? No, it is added to it the glycemic variability, the roller coaster figure as we are seeing in the blood glucose level, as the glycemic variability is connected to inflammation, the production of the free oxygen radical and the presence of oxidant radicals will lead to the occurrence of microvascular complications. So this is publication seeing the glucose variability with the occurrence of retinopathy in type 1 and 2, other about the micro and macrovascular complication, and even looked into the cardiac autonomic neuropathy, which is reflected by the baroreflex sensitivity, again, looking into the glycemic variability and having even associated with the left ventricular global systemic function when you're looking into the glycemic variability and the occurrence of myocardial infarction. So it's not only this, but even for the aortic stiffness. So the less time in range you spend and the higher glucose variability, the more aortic stiffness you're finding. So it's not just the long-term micro and macro and pregnancy, but even for the acute, and you can see this, the periodontal disease was again associated with the glycemic variability. The same consistent figure between all diabetic complications. And even this actually looking into another adverse effect, which is the hypoglycemia. So if you're having day-to-day glycemic variability, this will increase the incidence of hypoglycemia and mortality, and moreover to the well-being and the quality of life in those patients. So we have to look at this roller coaster, the bouncing blood glucose, look how flat and narrow the standard deviation should be. And again, to the consensus guidelines, how we should look to the coefficient of variation to be around the 36%, which is a key metric of glycemic variability for defining stable blood glucose. Also, the mean amplitude glycemic excursion, which is a parameter not dependent on the mean glucose value, and it quantiates the major glucose swings and exclude the minor ones. And this is very important looking at the glucose tetrad and how those things affect the blood glucose values. So now we have a plethora of glycemic metrics. And looking into Antonio Cirillo, that has published again in 2020, 15 years after his first publication in 2005, looking into the postprandial hyperglycemia. Again, in the same journal, he's stressing to add glucose variability as one of the risk factors to cause diabetic complications. And that's why time and range has been seen in different clinical trials as a primary outcome, preventing renal loss in diabetic, as well as even diabetic retinopathy. This was big trials funded by NHS. So are we now moving HbA1c with the time and range hand in hand, or are we substituting another parameter of glycemic control and microvascular complication? Because this is very crucial. And I'm going to show you a very interesting study, a little bit scary, the effect of long-term glycemic variability on the incidence of cardiovascular disease and mortality in subjects without diabetes. So this was a nationwide population-based study from China, and look, they were normal. They didn't even have diabetes. And if you have looked to the figure, you can see the consistent negative correlation between the glucose variability together with the myocardial infarction, stroke, as well as all causes of death. So the striking balance between both hypoglycemia and hyperglycemia measured by the time and range is very difficult. We all know that the flight faces many turbulences during its journey, and so does our blood glucose values. Bouncing blood glucose will cause so many complications and leading to activation of oxidative stress. So I'm concluding here that the use of DCCT 7-point testing shows that time and range is associated with vascular complications similar to the HbA1c. And data available confirming that time and range correlates with long-term diabetic complications. And time and range should be an acceptable endpoint for a clinical trial. In future, HbA1c will add little to the wealth of information generated from the CGM trials and metrics that could we take it with us for decision making. So at the end, I'm trying to after this discussion, to say that A1C is not the only factor contributing to the diabetic complications. And back to the photo that I have showed you at the beginning of my presentation. So this was drawn by Leonardo da Vinci in 1490. And it was actually a model of the perfect proportion between geometry of mathematics and art, and how this was correlated with Antonio Cirillo about the perfect hyperglycemia. Look at those points, the HbA1c, the fasting first and second hour postprandial blood glucose, time and range, short-term and long-term glycemic variability, hypoglycemia, and recovery from hypoglycemia. And I'm ending that the message Leonardo da Vinci wanted to convey here, that everything connects to everything else. So be careful about the blood glucose variability and the vascular complications and injury. Thank you so much.
Thank you, Professor Nancy, for your very nice lecture.
Thank you, Dr. Sandid. Thank you so much.
Very important, scientific, clear, and informative. Now we move to our third speaker, Professor Asma Deeb. She will talk in 20 minutes also about time and range for SMBG patient. How do we adapt? Professor Asma, please.
Thank you very much indeed, Mr. Chairman. Good evening, ladies and gentlemen. Thank you very much for joining us in this symposium. Time and range, a very hot topic in diabetes. I don't really see a point of me talking after a very convincing two talks before me, Professor Malik and my friend and dear colleague Nancy. We have all seen that time and range is not only important giving meaningful clinical data, but it closely correlates with complication. We even heard that Leonardo da Vinci apparently agrees on that, according to Nancy. Very nice. Art and science always go hand by hand. The area that I would like to discuss here is nothing fancy. The concept we know, time and range is important, but what I'm going to talk about is what if you don't have the fancy technology of CGM? How can we utilize the SMBG, self-monitoring blood glucose, and can we, a way or another, utilize the data obtained from SMBG to convert it into as meaningful as possible to indicate time and range? So that's what I'm trying to talk about. And this area really fascinates me. And I really hope that our colleagues, perhaps mathematicians, statisticians, help us, because it goes beyond clinicians here, how to play with numbers, especially when it comes to big data. Perhaps some way or another, utilizing artificial intelligence, we can convert. So that's the theme of what I would like to talk about. Nancy spoke at length about HbA1c and how important of a metric it is to predict complications. And we've seen clearly from previous studies and breakthrough studies, very major studies in the field of diabetes, the correlation between HbA1c and complications. And we all know that for every even 1% reduction in HbA1c, significant reduction in complications, and not only complications, even death from diabetes. So that's undebatable. The other very interesting topic about the complex diabetes, the complex disease of type 1 diabetes in particular, is the issue of glucose variability. Studies showed that even in patients who achieve the target range of HbA1c, there will still be hypoglycemic attacks acutely, as well as hyperglycemic attacks or excursions. So that's well known. This is the natural history of type 1 diabetes. Hence, we cannot really rely on HbA1c only, but glucose variability is something not just academic, but it's very directly implicated clinically. Not only it's correlated with complications, but it also affects survival. So we're not talking purely about morbidity, but also mortality when it comes to glucose variability. So very important concept in diabetology. We did say that time and range is a very important metric, and there are some parameters within the time and range that are incredibly important because they can be considered as keys and they can be utilized for clinical practice. An example is hypoglycemia or time below range. It's well known that it has direct implication on macrovascular complications. And also, as I've said in the previous slide, that glycemic variability is a possible marker and an independent predictor of diabetes complication. So we've seen very nice photos in Prof. Malik's initial lecture, much nicer than my humble slides, but the concept is the same. We all would love to see something like this in clinic. Colorful pictures, very meaningful, big data pooled into meaningful reports with color codes of what we want to see and what we do not want to see. And it's very important. It's not just because it's tidy and colorful. A question comes, why do we need an equivalent? We all agree that CGM is great. We all agree that it will provide time and range, which is very important. Let's put that aside. So why do we need an equivalent of time and range obtained by CGM from self-monitoring glucose monitoring or from blood glucose monitoring? That's the question that I was tasked to answer. Well, we need that because diabetes is common. I mean, this is a slide from IDF data showing that there are at least 425 million of people with diabetes. And out of those, there are around 39 million of people with diabetes in our region. And these people use self-monitoring. They prick their fingers and they manage their diabetes based on pricking their fingers. So we need to find a way on how to help those in coming up with a parameter that we can utilize in the same way that TIR or time and range is utilized from CGM. And we are talking about 500 million people. It's not a rare disease that you can manage it one way or another. Can we afford for 500 million people to go on CGM? I will leave the answer to you. Just one word about health economy, which I made myself, or I forced myself to get some interest there recently. And it's really fascinating when you look at the magazines talking about the CGM market in our region, Middle East and Africa. We might think that Middle East are not a huge contributor in this field of the market, the money where dollars go to buy CGM. And in one study, or it's from one intelligence report, it shows that the Middle East contribute with about 37% market share of CGM. And before you get super excited about the contribution of the Middle East to CGM economy, I will tell you this amount of market share is not equally distributed throughout the Middle East. So there are still people who cannot afford to use CGM. In fact, majority of this market share comes from Saudi Arabia. So while people in Saudi Arabia can afford such a fancy CGM, the rest of Middle East and North Africa, according to this intelligence report, have a minority when it comes to contribution of market share in CGM. So back to my point, there are still millions of people in our region who prick their fingers and get that data. And my point is how we can utilize that data and convert it in a metric, one way or another, to utilize it the same way as time and range utilized in CGM. That's where the interesting point is. So that's what I have already said. Majority of patients with diabetes are using capillary glucose monitoring. And it will remain so because capillary blood, this is the gold standard, even with the huge success and the optimization of the CGM and the high accuracy and this very low MARD that we nowadays hear about, people will continue to prick their fingers to see what their blood sugar status is. And I talked about affordability in the Middle East. So that's the way I think about it when people raise this question, do we really need to find an equivalent to this? So let's just have few revision of the concept of the self-monitoring of blood glucose. It is a golden standard, isn't it? When monitoring patients, it's capillary, so direct blood. We're not talking about interstitial fluid. We're not talking about the lag and everybody else, which make CGM a limitation. And people in different guidelines, they were told that if you have type 1 diabetes, then you need to test at least 4 times. And if you have type 1 diabetes and your diabetes is not well controlled or you are sick, then you need to check 8 to 10 times. We know that. But studies show that even increasing frequency might not be sufficient to prevent hypo or hyper. And this issue is particularly important when we talk about nocturnal hypoglycemia. No matter how many times you check blood sugar throughout the day, it can be completely different when people are asleep. So, difficult task. Increasing frequency alone is not really gonna solve the whole issue. So, let's critically appraise the self-monitoring glucose, blood glucose. Can we employ it to measure variability one way or another? If we think about it, the SMBG can detect metabolic anomalies, and it's highly correlated with HbA1c. And there are hundreds, if not thousands, of trials which were undertaken utilizing it. So the immediate answer to this question as whether we can employ it to indicate variability should be yes, because of these reasons. Despite that, many authors still do not agree that SMBG can be used to measure variability because yes, it can detect metabolic anomalies, but only if the patient chooses to measure glucose at that time. And also, there are multiple trials which looked at the SMBG to examine variability, but limited number of trials which showed strong evidence that this is the case. So there is still some gray area in this issue. I'm just flagging up here an example of a model day for blood sugar. And with this incredible variability, I'm not really sure whether individual points can be scientifically taken to measure variability, because a patient like this have readings all over the place. So let me just go back to the main principal questions. We have a gap here in this millions of patients who utilize self-monitoring blood glucose. And that gap is, we don't know, there is limited evidence that the blood glucose values obtained by the SMBG can be pooled together and expressed in a way that can be utilized in a similar way that we are utilizing time and range. This is the key point. I have added this line without the permission of Dr. Malik. I took it from one of his slides. I really liked it because this line assumes that the time and range, when we talk SMBG language, should be equivalent to number of points in range divided by total number of points multiplied by 100. Can life be as simple? If that's the case, perhaps no one of us will have gray hair ever. But there is always a start because it's well known that SMBG correlates very well with the blind, for example, the blind CGM. Many of you might have heard about the REPLACE trial, which talks about the strong correlation between the blind CGM and the SMBG. And I'll finish off by a couple of studies very quickly talking the same concept. So this is the first study of the two, talking about time spent in range assessed by self-monitoring blood glucose and its correlation with HbA1c. This is what the result shows. Very convincing, not surprising results in that SMBG in target correlates inversely with HbA1c. So the higher the number of points within target, the lower the HbA1c. Where is the surprise there? Perhaps the slight surprise is the same data taken over 2 weeks, the result of those, and this inverse relationship is exactly the same if it was done for a month. So whether you provide data obtained over 2 weeks or you provide data obtained over a month, the result is the same and the correlation is there. So that's reassuring. But let me take you to this other study. This is a short report talking about the same thing, the correlation between points in range assessed by SMBG and compared to HbA1c. So please look at these 3 bars. This is a study was done in adults, over 200, I can't remember the exact number. So 200 adults, just over, on insulin pump therapy. And what authors did is they have pooled their data into 3 categories based on their HbA1c. So as you can see here in the x-axis, we have the first bar showing data from those whose HbA1c is less than 7.5, achieving target. And the last one is HbA1c above 9, and the middle one is HbA1c between the two. And the white, gray, and black bars in between showing points in range, points above range, and points below the range. And I want you just to concentrate on the first bar, which is hemoglobin A1c less than 7.5. Even those patients who achieved target, they only have 57% of their points in target. And they still have almost 30% of their readings above the target. And the significant 13% of their reading were below the target. So are we now talking that if you have 57% of your SMBG in target, will you achieve less than 7.5% HbA1c? That's the question. Interesting study, I thought, because we are used to the concept of 70% time in range is equivalent to 7 gram% of A1c. Now, this study is talking differently. It says you only need 57% of points in range to achieve the target. This is my last slide, Mr. Chairman, ladies and gentlemen, and I'm attempting here to answer the question, but unfortunately I'm ending with more questions. So what do we need to have an equivalent time and range from SMBG? Well, we need to determine the minimum number of data input to get relevant information. And when we say minimum, when I say minimum data input, I'm talking frequency as well as schedule. We also need to come up with a method to indicate in all glucometers used for this purpose to indicate the timing, not only the timing, but also the schedule. And by schedule, I mean before meal, after meal, before exercise, after exercise, and so on and so forth. And we need to translate this big data one way or another, preferably through artificial intelligence, into a meaningful parameter. We might need to come up with something novel, not TIR, something else for SMBG. And of course, we need research to confirm the correlation and the reliability. With that, I'm going to stop, ladies and gentlemen. More questions than answers, but I will let you enjoy the rest of the symposium. Thank you very much.
Thank you, Professor Asma. As usual, your lecture is very, very important, scientific, informative. Thanks again. I remember the audience, please type your question in the chat in the right of the screen, and we will try to answer as many questions. Now, we move to our last speaker, Professor Bassam bin Abbas. His topic in 20 minutes also, how can we improve the time and range to our SMBG patients? Please, Professor Abbas.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Good evening, ladies and gentlemen. First, I would like to appreciate LifeScan for inviting me to the Middle East and Africa IDF Diabetes Summit, the Blue Circle program, which is discussing mainly time and range and its impact and its role in SMBG using patients. I'm really very thankful for the introduction by Dr. Mohammed Sandid, and I'm very happy to be among my colleagues, Dr. Asma, Dr. Nancy, and also Dr. Mohammed Hassanin. The speakers talked about time and range in some depth, and I noticed that Dr. Asma Deep was referring to the points in range. So my talk would be a little bit continuation of her talks to the Asma Deep talks. And I'm trying to answer this question, which is a very difficult question to answer actually, how to improve time and range in patients using self-monitoring of blood glucose, in patients using the blood glucose meters, the traditional meters. It's a very difficult question. I will try just to, in the next maybe 20 minutes, if the chairman allow me, I can take extra minutes trying to answer this challenging and difficult question. I will go 3 steps backward, trying after that to speed up and fly. Basically, we have 2 categories of glucometers available for us. We have the traditional glucometers. They are old, but they're not outdated. This is a very important statement here. They are old glucometers, but they're still in use. And we have the new ones, the continuous monitors. And these are the continuous CGMS available in Saudi Arabia. We have the Freestyle Libre, we have the Guardian, and we have the Dexcom as well. And this is the way we are classifying the continuous glucose monitors into personal and the professionals. The professionals one usually used by the physicians, and they are giving it to the patients to use it for a while. Then they will return it to the physician. The physician can look at it and can download the data. So the numbers are not available for the patients. Versus the personal ones, which can be sub-classified into real-time CGMS like the Dexcom and the Guardian, and the scanned CGMS like the Freestyle Libre. And here's the difference between the 2. The first one giving you readings immediately. You can see it over the 24 hours. I mean, it will last as long as you are using it, and providing you with the automated alarms and alerts. The other one, like the Freestyle Libre, you can see the number when you are scanning the sensor, but obviously you can download the data and the device is giving you a continuous reading. I'm sure the audience, all audience are aware about the benefits of the continuous glucose monitors. And several studies like the Diamond, like the Impact, like the Replace, all of them showed the benefits and the advantages of the continuous glucose monitors in improving the glycemic control, in improving the variability as presented by Dr. Rashid and by Dr. Nancy as well. So it did, these devices reduce the events and the duration of hypoglycemia, especially in patients with hypoglycemic unawareness. It did improve the events and the timing of hyperglycemia as well, and eventually improve the A1C in type 1 and in type 2 diabetes. And not only that, but also it did improve the neonatal outcomes in pregnant ladies using these monitors, as shown by a recently published paper called Concept. When it comes to children, by the way, parents feel less worried, more confident about their child's safety, particularly among those who are having hypoglycemic unawareness or who cannot express the signs and the symptoms of hypo and hyperglycemia. So, if you ask me from where we are getting these benefits, because of the advantages very clear of the continuous glucose monitors, they are less invasive, and that's true. Less finger sticks, more data, and this is true. These devices giving you more data because the continuous reading, you can also share it with your healthcare providers. And what is unique about these continuous monitors, it's provided with alerts and alarms, which is very useful for children and also for others with hypoglycemic unawareness. So everyone is aware about these benefits. But I have to stop here and say, but or however, this is one of the benefits, the less invasive, and it's true. Nobody can say anything about being less invasive in comparison to our traditional glucometers, but also we have to widen the picture, and also we have to look at the other side. These continuous monitors, they have sensors, and these sensors sometimes, not always, things are improving a lot. Some of them are painful. And a good number of our children, to fix these sensors, they have to use adhesive tapes. And sometimes the skin can be irritated to these adhesive tapes or to the sensors. Also, some of the devices, some of the continuous monitors need calibrations. So we are talking about another 2 finger sticks per day for calibration. So you have to keep this in mind. I'm not saying that the continuous monitors are not good. They are excellent as shown by our previous speakers, but you have to put these challenges in your mind. The data, people talked about the data, about the continuous data, but on the other side, these are the challenges. Sometimes the data are too much for the healthcare provider as well, not only for the patient, which can lead to what's called data fatigue, and also increased learning. We are learning a lot. Physicians and users, we are learning a lot from these devices, but sometimes can lead to overcorrection with insulin in case of hyperglycemia, or overcorrection with food in case of hypoglycemia. So you have to keep this in mind as well. Sometimes people are complaining of increasing math or calculations by using these modern devices. About the data, yes, they are continuous, but sometimes the signals will get lost, leading to interruption in data. So I'm just trying to summarize some of the challenges of this data, and I will tell you in a minute why I am listing these challenges. Data sharing, it's unique for the continuous glucose monitors, but sometimes the healthcare providers whom you want to share the data with him to act on, he's very busy and he will not get back to you. So keep this in mind. And sometimes the healthcare providers themselves, they don't have the experience to look at this tremendous amount of data. So I'm saying that these advantages and these benefits are not without drawbacks and challenges. The alarm and arrest, excellent, as I mentioned, for those with hypoglycemic unawareness who cannot recognize the symptoms of hypos and hypers, excellent feature for the continuous glucose monitors. But sometimes it might lead to alert fatigability, and a good number of children using these continuous monitors, they have to switch off these alerts and these alarms, and we're not recommending that, but because of too much of noisy alerts. The arrows themselves, they have a meaning for these arrows, and every brand has its own interpretation for these arrows. I can tell you that some of the physicians are not aware about the meaning of these arrows. Let me give you here just a snapshot of the Freestyle Libre trend arrows. And what does it mean? For example, the arrow which is straight up indicates that your blood sugar is raising by 2 milligrams per minute, which means after half an hour, you can expect your blood sugar to be high by 60 points. So you have to memorize these points, and you have to teach your patients about this. So not only that, for example, we are using the arrows for more corrections. We are giving patients insulin based on the carbs consumed, based on the blood glucose reading, and that's true. But nowadays, by using these continuous glucose monitors and the trend arrows, we have to correct for these arrows as well. I can tell you that maybe a good number of our endocrinologists, they don't know how to correct for that. You have to go back. If you want to correct, you have to go back to what is called the correction factor. So it's a little bit complicated. Again, I'm not saying the alarms and the alerts are not good. They're excellent, but need also to spend more time in teaching your patients and also teaching your trainees as well. Back to what Dr. Ahmed was talking about the percentage of children using the continuous monitors. I don't have the exact figures. I don't have it here even in Saudi Arabia, but I can tell you that a good number and a good percentage of our children and maybe our adults who are on insulin, they are not using the continuous glucose monitors, maybe because of the cost, maybe because of the insurance coverage, maybe because of the challenges I mentioned. There is a reason, I don't know why, but I found this paper talking about 6%. This was back in 2011 using the continuous monitors. Nowadays, things are much better, around 40%, but still low. So I can tell you based on this paper from US, I can tell you half of our patients are not using the continuous glucose monitors. So what shall we do with them? I have to be frank with you. I mean, Dr. Nancy, Dr. Rashid, everyone is talking about the time and range. Time and range cannot, as Dr. Asma just mentioned, cannot be measured by the traditional glucometers. And today there is limited evidence that the traditional glucometers can measure these new metrics like the time and range, above range, below range, and also the variability. However, the new glucometers, the blood glucose glucometers with the new features can help. Can help in what? Can help in normalizing, let's say, or putting the points in range within the accepted range. And eventually, if you trying to put the points in range, and I will tell you in a minute what's the difference between point in range and time in range. If we are trying to put the points in range within the acceptable range, eventually this will improve, inshallah, the time in range. And this is the aim of my talk, how to improve points in range in patients using the traditional glucometers, in patients using the blood glucose meters. And I would like also to present some of the features of the newly available glucometers, which might help putting numbers or readings or values or points within the acceptable range, hoping for better time in range. Before I proceed, I mean, we have to be frank that the glucometers using blood are still the gold standard when it comes to the accuracy. Yes, the continuous monitors providing us with a good number of information, and they have excellent features, but when it comes to accuracy, I think the blood glucose meters much more accurate. This is what we mean by time in range versus points in range. Time in range measured by the continuous monitors. Point in range, this is the feature of the traditional glucometers. Time in range means that the glycemic time is spent within the acceptable range versus points in range, which is the blood glucose readings within the acceptable range. I mean, this is the difference between the two. This is the paper which was Asma talking about, but I just would like to tell you about, I mean, Dr. Nancy, Dr. Rashid, who was talking about the correlation between time and range and the A1C. The same thing, if are using the glucometers, there's a good correlation between the points in range and the blood glucose reduction by 0.4%. I mean, for every 10% change, I mean, in points in range, you are expecting the A1C to be reduced by 0.4%. When it comes to the time in range, we are saying the same thing, the same correlation. For 10% improvement in time in range, you are expecting the A1C to be lower by maybe 0.8%. So there's a correlation even in points in range, not only in time in range. How can we use the meters. I mean, selection of the meter is very important because it's very helpful to improve your points in range, and eventually, inshallah, this will improve your time in range. We have to look for a meter which is easy to use, easy to transport, not using the coding for every time you open a new strips box, and the readings can be measured as milligram per deciliter, millimole per liter. This take time very short, than in few seconds. The batteries should be rechargeable, memory, so you can go back and look at your readings in the past. The operation temperature, humidity should be acceptable as well, and the sample size should be very small, not taking that much of blood. Other new features like network connecting, Bluetooth enabled. We need a glucometer having these features because you can share your data with your physician. One of the features of the continuous glucose monitors that you can share your data with your physician, your healthcare provider, and he's supposed to get back to you. So the same thing, if you're using this glucometer with this feature, you can do the same thing. There are a lot of features. If it's there in the glucometers, this is very helpful for you, including the color range indicator and mentor messages. And in a minute, I would like to tell you some good things about these features. Also, people talking about the applications. If the glucometer has connected to your cell phone, your smartphone with an application, you will find the diet, you will find the medication listed there, all events, including sports, and you can look at their effect on your blood sugar as well. The important statement here is applicable for the self-blood glucose monitor and also for the continuous glucose monitors. All these readings coming from the new meters, the old meters, they are a tool, they are not an intervention. So you have to teach your patients to monitor with meaning. You have to tell him, or you have to show him how and when to perform his blood glucose readings, how to record the results, how to present the result to his physician, and what is the meaning of highs and lows. And also you have to find out the effect of different events, including behavior, on the blood glucose reading. Okay, since the majority, since a good percentage, let me say, of our people are not using the continuous monitors, let's talk about the traditional glucometers with good features, or with some of the CGMS features, let me call it, trying to improve, as I told you, the points in range. One of the features is what's called the color coding or the color range indicator. So usually and normally the numbers are displayed as numbers, but if it's displayed as numbers and also colors, this is very helpful for the patient, because I'm telling you that a good number of our patients, I'm telling them the range is between 70 to 180, and he will come to me with 200 readings, and he is accepting that. But if you have it in color, which is above range is red, below range is blue, I think he cannot forget the meaning of highs and lows. This is a very interesting study. It's a survey, by the way, including about 900 people, and showed that 50%, half of the patient, they are taking no action if their readings above range, or out of range, if it's high or low. So whether this group of patients, whether they're using continuous monitors or the traditional ones, they will have no actions if their readings is out of range. So this group of people need education as well. Let's look at the effect of some of the features of the glucometers, like the color range indicator, on interpretation of the glucose values. And this is a paper was published a few years back. Look here. Patients who are using these glucometers with this feature, with the color range indicator, significantly improve their ability to categorize their glucose results, whether it's low or within the range or below the range. So the coloring has an effect on these patients and interpretation of blood glucose. Another question here also trying to answer, the associated values with color make a patient more inclined to act. As I said, the majority of our patients, they are not taking any action. So providing them with the glucometers with this feature, the color range indicator, does it help? The answer, maybe I'll give the slide. The answer is yes. If you look at the left side of the slide, because the slide showing you patient with type 1 and type 2 diabetes. But if you look at the left side of the slide, you can tell that the patients are more inclined to act if when the glucose results are displayed and shown in a colorful, let me call it, way. Not only that, They are more, patients who are using this kind of glucometers prefer to view and review the blood glucose if they are colored, not only just numerical values. The third question is also talking about the same thing in the meter with these color features. Does it improve eventually the glycemic control? And the answer is yes, based on the study which is called ACCENT study. Here is the result. After 12 weeks, subjects who switched to a meter with a color range indicator showed around 0.4 or even 0.5% reduction in A1C. So eventually this feature in that glucometer improved the glycemic control. Okay, this is a comparison study. They are comparing people who are using meters without color and meters with color, and there is a big difference. So at the beginning, they were the same, but by shifting to a meter using this color range indicator, there was a significant improvement in A1C. Okay, another feature is mentor messages. I mean, we are talking about a meter which providing people with messages, like in case of flow, he will tell you, please take a drink a juice, for example. If your blood sugar is high, for example, you have a pattern, you have to act on that. So some of the meters are giving you numbers, colors, and also messages which are very helpful for the patient. Let's look at the effect of the messages on patients. Here is the paper talking about, can meters with mentor messages support self-management goals? And the answer is yes, based on this survey, which was distributed among 350 physicians from 5 countries using 4 meters. And the majority of these physicians prefer meters providing additional insights like messages. And here's the result. You can see different colors here. We have the red, this is 1 meter, yellow, another meter, blue, another meter, dark blue, another meter. The majority of the physicians prefer the meters with additional insights like mentor messages, like color coding, and these things. Bluetooth connectivity and application. Does it have an effect? The answer is yes. Let's look at this result. Wait, if you are continuously measuring your blood sugar, as Dr. Asma has just mentioned, maybe 4, 6, 7 times, you can have the same profile, what's called ambulatory glucose profile, generated by some of the continuous glucose monitors. So you can do that to some extent, of course. This is another paper talking about getting remote advices from your healthcare provider if this meter is connected to an application. Does it help? This is the question for this answer, for this paper. And the answer is yes. If you are using a meter and you are remotely connecting and communicating with your healthcare provider through an application, this will reduce your A1C by maybe 0.4 up to 1% in A1C. So in conclusion here, meters with application, with mentor messages, can help patients in improving their glycemic control. This is a paper from Saudi Arabia, from our colleagues from the military hospital, from Mohammed Adwish. Also, they looked at almost 85 patients using meters having this feature, the color range indicator, and this is their results. There's a significant improvement in A1C and the rate of hypoglycemia, and also they feel more comfortable with these devices. I will finish by showing you this paper. It is a survey, actually, involving a good number of healthcare providers, asking them about their satisfaction with a meter having all these features like mobile applications, color range indicator, and others like mentor messages. And almost all of them, between 80 to maybe 95% of these physicians, which included diabetic nurses, endocrinologists, diabetologists, primary healthcare physicians, almost all of them, they like the features of this meters, and they think this will improve the point and range, I mean the readings and the values and range, and subsequently we are hoping to improve the time and range. So in conclusion, I will finish by this slide. SMPG is still the cornerstone of diabetes care because of its accuracy. CGMS, we're not ignoring the benefits of the continuous glucose monitors, very helpful to obtain immediate feedback on the current glucose levels, as well as the direction and the rate of change, and should be used as a complement to our traditional glucometers. New glucometers, I'm talking about the new ones with additional features, having additional insights, very helpful to improve children's point and range, and inshallah, subsequently, time and range. Thank you very much.
Thank you, Professor Bin Abbas, for your nice information and this valuable lecture. We have touched on various aspects on this webinar, a new and important subject. And now we move to the discussion. Can I ask my friend Hassanin, Professor Hassanin, to read the question addressed to the lecture?
There is one question perhaps Dr. Malik can address related to neuropathy and time and range.
I think I saw some publication, one or two, and the time in range improved that you have reduction for vascular complication and especially for acute coronary disease.
Could I add something, Dr. Hassanin, also?
Sure.
The studies have shown for the cardiovascular risk factors looking into the aortic stiffness as well as the carotid intima media thickness as a part of the cardiovascular mortality and risk factors. Also, they have looked into the cardiac autonomic neuropathy through measuring the barosensitivity reflex, looking into the variability in heart rate as well as variability in the blood pressure. And all of them in the studies of type 2 diabetic patients showed correlation, time and range, as well as the cardiovascular, as well as the cardiac autonomic neuropathy. So the vascular events correlated with the time and range in the studies.
Okay, what about neuropathy? Would it also equally relate? We know that neuropathy is much more related to glycemic levels. And Rashid or any of the panels, have you in your search for the evidence found link between time and range and diabetic neuropathy?
I can take that because I have shown already one of the studies from China that was published in Diabetes Care, looking into the 3 microvascular complications. So it was not only the retinopathy severity as well as the level of microalbuminuria, but again, they have looked into the peripheral neuropathy, and it was also correlated with the time and range. And I have showed this slide with the 3 microangiopathy correlating with the time and range in this study.
Yes, Dr. Muhammad, I agree with Dr. Nancy because one of the papers, which is a very famous paper, showing that maybe for every 10% improvement in time and range, you'll be getting almost 20% reduction in the long-term diabetic neuropathy.
Okay, so Bassam, since you're on, there's a question here for you, for someone with asking about a person with type 2 diabetes. How many times should they check SMBG to get the information that would be equivalent to time and range?
Okay, if he's on insulin, so we are treating him and we are managing him as a case of type 1 diabetes mellitus. Maybe if he's on insulin, so the more he shakes, the better the outcome will be. So, generally speaking, for patients who are using insulin, because I'm a pediatrician dealing with children who are using insulin, we are recommending, as explained by Dr. Asma Deep, between 4 to 6 times per day, and more frequently in case of sickness, for example, or any unusual event. But generally speaking, the more shakes, the more better outcome, as long as he's acting on these abnormal readings, whether they are low or high.
Let me add also, Dr. Hassanin, to what Asma has added in the presentation. All the presentations were great, But let me just add from the big GCCT trial that was computed to time and range, they have showed the correlation between the 7-point testing, which means that the participant measured pre and post meal, as well as bedtime. And even with the other studies, when they have added the 8-point testing, which was the nighttime, all of them showed correlation between time and range and HbA1c. So we are talking about 7 to 8-point testing, but they have to be validated and done. Even if you're doing, according to the authors, if you're doing this 8 or 7 times testing per day for a consecutive 3 months, and then you computed this to time and range, again, it will be correlated.
So Asma, let me ask you a question. You have shown the very important figures of prevalence of type 2 diabetes and the global prevalence of use of CGMs coming from the Middle East. So the majority of the Middle East are not able financially to get CGMs. So in your opinion, and you're a pediatrician, how can you motivate the patients to do more SMBG? Because they cannot get CGMs. I'm not saying the small proportion who do. The regular ones who cannot afford it, but they're not doing enough. How can they be more motivated with clearly understand the more they do, the better the information we have? So how can we reach that sort of tricky situation?
I'd love to start by motivating insurers to pay for CGM for these children who cannot afford it, before motivating parents, because what disheartened me is the big issue of health disparity. These are all children having diabetes, and it's disheartening that some patients have access to it while others do not. But that's not the real world. If we go back to the real world, how do we motivate? I spent 20 years doing pediatric diabetes, and I spent my time trying to counsel, motivate, and encourage. It's not easy. It's easy for us to encourage them, but it's not easy because it's a chronic disease. There are multiple ways of doing this. It's either encouragement or empowerment or warning about complications. But we all nowadays, like Bassam said, with this era of connectivity and apps and things, we can show them audio-visually how important the correlation is between the red color, the green color, and the blue color in improving the percentage in time and range. This is a difficult question, Mohammed. I think we need a psychologist to answer this question.
Sure. We have over 1,000 participants for this webinar watching us now. Now, the vast majority of them will be treating patients who are not financially able to do this. I don't really know. Perhaps this is a question to our chairman today, Mohammed Sandid. So how can we, okay. I mean, we know that some of our patients are struggling to get insulin. So the reality is many of our patients cannot afford insulin, cannot afford blood glucose strips. In many countries, blood glucose strips are not free. The patients need to go and buy it. So how can we motivate or improve the cost effectiveness of diabetes management in general? I mean, I know, Mohammed, that you're very heavily involved in, perhaps anyone can answer this. I mean, the reality is in our MENA region, there are so many people in many countries, they cannot get insulin, and blood glucose strips are not part of the free prescriptions for those who are in insurance. So is it really important for them to simply monitor or go to the extreme and get their financial aspects restricted very much to buy CGMs?
I think it's a financial aspect in our region, because maybe the cost of the test is very important in our countries, in some MENA region. I have a question. Is it possible for a patient with a first insulin-dependent diabetes to convert to the second insulin-independent diabetes and vice versa? Malik, can you answer this question? Are you hearing me, please?
So we have two questions now that we need to address. Let's not ignore the other. I think both of you, Rashid and Nancy, were trying to answer the question about the reality of affordability of diabetes treatment, whether it's insulin or strips or CGMs.
I think I agree with everybody that diabetes is very complex disease and heterogeneous population. I think we have to have some condition and have some group of patients. The majority of patients in MENA region in our countries haven't any financial to have this new device for their following. But I think you have some part of patient like hypoglycemia unawareness, like severe hypoglycemia, like type 1 diabetes, pregnancy, which need this device and time in range in their progression. We have to separate different population for this indication. For the second question for Mohammed, I don't hear your question. Please, can you repeat it?
I think the question was from one of the attendees asking, can a person change from type 1 to type 2 or from type 2 to type 1?
It's not easy because I think it's the same question for the number of glycemic capillary per day. I think it's two different population, but they which determine this difference between two. It's the sort of medication and insulin or therapy for the two type of diabetes.
Okay. Nancy, you work in Egypt. The vast majority of the patients are self-paying. Small proportion of patients have insurance. I mean, usually parents are a bit more keen to get out of their way when they are talking about their child. But how do you see the situation where obviously you work also in the university and you can see the diversity in people's finances?
Yeah, thank you, Dr. Mohammed. That's what I was just trying to implicate. First, if you have a stable case where you have number and percentages of the complication that children and adolescents with type 1 diabetes are facing, so you can talk to the health insurance authority by how you can change the SMBG into CGM. And that's actually what we're trying to do now, gathering data of the complications and look at the cost effectiveness treating patients with SMBG, where you don't, where you have to fight with a child to measure the 7 or 8 or 10 times per day, according to your daily practice, your meal intake, or exercise, your stress or exam that you're having, versus just swapping or scanning with a CGM. For those who cannot afford, as my dear colleague Bassam has already indicated, that the new BGM with the color coding, and I have talked even previously with the companies, try to make like emoji, happy face. So if you're having a good BG number, the child can interpret this when you're having a smiling face, for example, so you are within range. And if you're just, for example, drawing a juice or a candy, so this implicates that you're having hypo and you take an action. And I don't want to put a crying emoji or a very stressed emoji, because I don't like to increase the stress of parents, either in the hyper or the hypo. So, for example, if they're having hyper, they can, for example, put an insulin injection photo. And if they're having hypo, simple carb that can be taken, and the good smiling emoji if they are in range. So we're talking about different levels, level to the health insurance and the government, where they can help finances, but this has to be with a solid data of the cost effectiveness, whether treating the complications or having the patients within range, and then convincing parents as well as children how to keep in range to monitor more and more, even if you don't have CGM. We have in Egypt actually so many charities and parents who are helping each other, so they can collect, sum of money for those who are in real need of having the CGM or even the continuous pump therapy. So there are so many solutions that we can do to get more engaged and involved, both for the government as well as families and their caregivers.
Thank you, Nancy. But Sam, you work in Saudi Arabia, you work in a big institution. Nevertheless, many of your patients are using SMBG. You're a big fan of the facilities that are there. Tell us more about your experience of, I have used the LifeScan meters 20 years ago when I was doing my research and demonstrate to the patients the color coding that was there in the software. And I personally found it very educational for the patients. Other glucose monitors have more or less similar schemes or facilities that can help the patient understand the percent of time of the readings. Obviously, it's not the same parameter, it's not time in range, but readings in range, regardless of the word in Arabic exactly what it would be. And that perhaps reflects the glycemic situation of the patient, not to the same extent. But from your experience with the modern types of blood glucose monitors, how can you make use of this and advise the junior doctors or the primary care physicians or even the pharmacist or the nurse attending the meeting on the value of such simple facilities?
Okay, yeah. As you mentioned, Dr. Mohammed Al-Hassan, not only LifeScan, a good number of companies making these glucometers, having the same features like the apps, like sharing data, like the color coding, I call it, like the messages. So, I mean, these features in general are very helpful, and our local study from Saudi Arabia showing the same thing. Adding this feature to the glucometers was very helpful. The problem in our children who are using the continuous glucose monitors, they are not having it. The good number or good percentage of children in Saudi Arabia, because of free of charge, the Minister of Health is distributing it free of charge. So I can tell you a good number of children in Saudi Arabia, they have the freestyle library. But the problem is not having these technology or don't having them. The problem how to act on them. I have a good number of these children in one of the clinics outside my King Faisal Specialist Hospital, where we're seeing around maybe 2,000 children with diabetes, and almost all of them have these devices, but they are not acting on the numbers. So the problem is not seeing these readings or these profiles. They have two problems. Number one, they are not acting on these readings. Number two, they don't have an easy access to the physician to help them, or educator to help them in adjusting their insulin dosages. This is another issue which is very important, whether they are using the glucometers or whether they are using the continuous monitors. We have this problem. That's why I have a previous presentation talking about the virtual consultation or the virtual contact between healthcare or even nurse practitioners and patients. I think this will help at least children, and I'm doing only pediatrics, at least our children and our parents, they can contact us easily through these digital applications, which are private ones, by the way, and some of them approved by the US FDA. And we are getting some applications here like them for virtual coaching, we call it. And this is very helpful because they can contact, the parents, they will have an easy access to the healthcare providers. They can contact them day and night, even outside the working hours. I'm sure these applications, which have been used for several years in the West, I'm sure they'll be having very additive value to our countries.
Thank you very much for mentioning this, Bassam, because I personally feel that there is a massive need for increasing the education aspect for our patients with a better role of educators, dietitians, nurse practitioners, and physicians when they have the time. And of course, the virtual aspect now, as we are reaching over 1,000 person tonight, we can equally, if this is a clinical aspect and a number of patients can log in and communicate. We all have our communication with our patients via WhatsApp and virtual clinics, and we advise on blood glucose monitoring. At the end of the day, blood glucose monitoring is very important, and to know what to do with it, which is your point of many patients have CGMs, and exactly the same situation where I work, many patients have different types of CGMs, but they don't know how to utilize them to the best. So it's not just about rushing to the latest technology. Perhaps we need to focus on the basic infrastructure, which is lacking in many of our big institutions, let alone of the private practice, where the physician cannot afford to spend an hour with each patient. I think we've covered so many questions, but I leave the floor to you. I was just going to ask the colleagues of any final comment. Yes. There's no more questions available.
I think it's necessary to work in our region, MENA, on two things. The first is the economic situation in some countries of the region and increase the education among patients and doctors. Here is the role of LifeScan company, I think. So thank you to all the distinguished lecturers who provided us with valuable information. Thank you to all the participant, audience, and organizer of this activity. I mean Amber's team, and don't forget to sponsor LifeScan company. Many thanks to the scientific committee, especially to Dr. Professor Hassanin, hoping that your permanent trust in the MENA IDF will remain. We hope that these difficult circumstances will pass and we will see you physically in the upcoming activity.
Thank you very much, Professor Sandid, indeed. And I just remind you with what's on the screen, please give us your feedback. Please complete the survey. It's always important to know what went well and what not well as future topics for future meetings. Thank you for all my excellent colleagues and faculty and our sponsors as well as our organizers.